Welcome to our program From Resistance to Resilience and Relapse Refractory CLL, Sequencing Strategies for Achieving Effective Continuous Care. I am Megan Thompson, and I'm joined with Dr. Thompson Coombs at today's program. I want to thank PeerView and the CLL Society for providing this session, and Lily for providing the educational grant for the symposium. And look out throughout the presentation for additional follow-up polling questions. We've also prepared practice aids that can be used to gain quick insights on dosing, other practical information on the BTK inhibitor class in CLL. And you'll see that there are CLL Society resources to share with patients, so please be sure to download these resources before we get started. Finally, please submit your questions throughout the program today using the live chat feature. Dr. Coombs and I will be available to address these throughout the presentation, and we'll also have some further discussion based on your questions during the Q&A session when we close. You can visit us at peerview.com/RRCLL24, and you can view the slides as well as the practice aids now and download them after the event. So as introduction, this is a slide showing that covalent and non-covalent BTK inhibitors are core treatment options in both the frontline and relapse refractory settings for patients with CLL. So you'll see covalent BTK inhibitors include ibrutinib, acalabrutinib, and zanubrutinib, all FDA approved for treatment of chronic lymphocytic leukemia. We also show that venetoclax, the BCL2 inhibitor, has a key role in this disease. And now the non-covalent BTK inhibitor pirtobrutinib is FDA approved as of December 2023 for patients with CLL who've received 2 or prior lines of therapy, including a BTK inhibitor and BCL2 inhibitor. And there's multiple ongoing phase 3 studies of pirtobrutinib in CLL. The non-covalent BTK inhibitor nemtabrutinib is also being tested in clinical trials and is in clinical development. This slide shows that despite advances with targeted agents with BTK inhibitor and the BCL2 inhibitor venetoclax representing the majority of frontline recommended treatment options, looking at real-world data, we still see in the utilization data a high number of patients receiving chemotherapy. So you'll see data at the bottom from 2020 to part of 2023, and still almost a fifth of patients have received chemotherapy, and over 33% of patients did not receive recommended regimens per guidelines in 2023. So this just highlights that there's still work to be done to really have our clinical practice reflect the most recent data in terms of targeted therapies. This is data that looks at a relatively large data set of patients and highlights the patients who discontinue a covalent BTK inhibitor therapy and BCL2 inhibitor experience in general poor outcomes overall. So you see the time at the bottom, the time from discontinuation to subsequent treatment failure, and by line of discontinuation. Overall, this represents that the outcomes after a BTK inhibitor and BCL2 inhibitor generally are poor as of this publication in 2022. And this is more recent data presented at the ASH meeting in 2023, looking at double exposed and double refractory CLL patients. So the double exposed patients, just to highlight, are patients who received a BTK inhibitor, specifically a covalent BTK inhibitor and venetoclax, but not necessarily being refractory or progressing on that agent. And then patients who are double refractory or had refractory disease to both agents. And this shows overall poor outcomes for these patients. So for example, double refractory patients, you can see at the bottom left, had a median progression-free survival of 6.8 months. versus double exposed patients had a median progression-free survival of 15.4 months. And then you see the overall survival on the right. This really highlights an unmet medical need at the time of this publication for patients who received both a covalent BTK inhibitor and venetoclax, particularly the double refractory patients. So our goals for today are listed here. We're going to attempt to augment your knowledge of the mechanistic, selectivity, and safety differences among the covalent and non-covalent BTK inhibitors. We're going to discuss skills that will help you capture multiple factors that can inform sequential treatment planning with BTK inhibitors. We're going to talk about the development of personalized sequential treatment plans for patients and examine specifically the use of covalent and non-covalent BTK inhibitors, and also discuss team-based care coordination, dosing, and safety management, as well as aspects of patient education. So I want to thank our partners at the CLL Society, and you can find the CLL Society online at cllsociety.org, who have helped partner and support this program with us. The CLL Society has many, many resources. You can find them listed here. I just want to highlight a couple of these resources. The Patient Education Toolkit is a helpful educational primer for patients. And then there's also a provider resource library that provides additional patient teaching materials, and these can be printed out as well. So now we'll turn to our topic, reinforcing new sequential treatment pathways in relapse refractory CLL. And I'm going to start by discussing the current standards and challenges in CLL. So here you see the NCCN practice guidelines for patients with CLL in the front line. And you'll see they're divided in the NCCN guidelines by the TP53 status. So patients first in blue without a deletion of the P53 gene or deletion of 17p or a P53 mutation, and then with. And you'll see that they look pretty similar here. And they're novel agent-based strategies. So you don't see chemotherapy listed on this slide. And here we also see from the NCCN some information on prognostic testing for patients with CLL/SLL, and we'll talk about this today during our presentation. There's several methods that can be used to identify prognostic variables for patients, and this testing really should be performed prior to initial treatment and with each line of therapy. With the exception of IGHV mutational status, which does not change over time, patients can acquire other cytogenetic and molecular abnormalities. So I'll just highlight that testing for deletion 17p by FISH is very important. Testing for the presence or absence of a P53 mutation by DNA sequencing techniques. And then it is prognostic, if available, testing for the patient's karyotype, as we know that complex karyotype of 3 or more abnormalities is associated with less favorable outcomes overall. So this slide highlights that ibrutinib, while is a very effective treatment for patients with CLL and undoubtedly has transformed the outcomes for many patients, we now know that at the time of clinical progression on ibrutinib, the majority of patients have mutations identified in the BTK cysteine 481 residue at the time of progression. These are activating mutations that lead to increased phosphorylation of BTK and downstream B-cell receptor signaling. A smaller proportion of patients also have mutations in PLC gamma 2, which is immediately downstream of BTK in the BTK signaling pathway. And resistance is a problem for patients treated with covalent BTK inhibitors, including ibrutinib, as seen here. But the other limiting factor can also be intolerance. Here you'll see data pooled from 4 prospective studies of ibrutinib, and you can see that ibrutinib could be discontinued for multiple reasons, predominantly either progression of the CLL or adverse event or toxicity. And here you just see the B-cell receptor signaling pathway. As we just saw, we see cysteine 481 mutations with acalabrutinib patients. This has also been reported with zanubrutinib-treated patients. There's less data on resistance to zanubrutinib than ibrutinib, but there is one report of 13 patients that progressed on zanubrutinib. 10 of 13 patients had BTK cysteine 8-1 mutations, but 7 of these patients also had a mutation in BTK L528W, which is a different mutation with different functional consequences. And so we see some emerging heterogeneity in resistance mutations to BTK inhibitors, and this currently doesn't impact sequencing or the standard of care, and more research is needed, but perhaps we'll have more information in the future. Non-covalent BTK inhibitors were developed, including pirtobrutinib, which we'll talk more about in this presentation, and is now approved for clinical use. And then there's others in clinical trial, including nemtabrutinib. And these non-covalent BTK inhibitors may address some of the limitations of covalent inhibitors, including resistance and intolerance that we just talked about. This also is a promising treatment option for patients with double exposed or double refractory CLL, which we saw earlier in the presentation have historically poor outcomes. And these agents bind reversibly to BTK, the non-covalent inhibitors, in contrast with the covalent inhibitors that bind irreversibly. So here I want to direct you to a video that we have developed that will focus on resistance to BTK inhibitors in patients with chronic lymphocytic leukemia.
Let's take a closer look at this specific enzyme, BTK, and its role in B-cell malignancies. In malignant B cells, BTK can become overexpressed. With overexpression, it becomes persistently activated, initiating a signal cascade. This leads to proliferation of the malignant cell, allowing it to thrive, resulting in patients having disease progression. Covalent BTK inhibitors, such as ibrutinib, acalabrutinib, and zanubrutinib, are dependent on binding the BTK site at a specific location in an irreversible fashion, resulting in inhibition of BTK activation. These drugs are incredibly effective for patients with B-cell malignancies, but unfortunately, resistance can occur. The most common resistance pathway identified is a mutation specifically at the C481 site, which makes it difficult for covalent BTK inhibitors to bind. This is the most common mechanism for covalent BTKI resistance in CLL and affects all agents in this class. Decreased binding efficiency results in resistance, which allows for increased BTK enzymatic activity, and ultimately for patients, disease progression. A new class of drugs called non-covalent BTK inhibitors has been shown to be effective even in patients who have disease progression and known resistance mutations after a covalent BTK inhibitor. One such agent is called pirtobrutinib, which is now FDA approved in relapsed refractory mantle cell lymphoma and CLL after at least 2 prior lines of therapy. This drug blocks the ATP binding site of BTK in a reversible, non-covalent fashion, which represents a different mechanism of action, and by doing so is able to overcome the resistance mutations that have occurred in patients who have progressed on a covalent BTK inhibitor.
Before we move on, I'd like you to take a moment, if you're able, to answer a follow-up polling question on BTK resistance mutations in CLL. Now we're going to turn focus, and I want to introduce my colleague, Dr. Coombs, who's going to speak now about updates on non-covalent BTK inhibitors in patients with relapsed CLL.
Well, thank you, Dr. Thompson. And let's kick things off. So I would like to review the phase 1/2 Bruin trial, which is the study that assessed pirtobrutinib. You see that this trial enrolled a wide variety of patients with relapsed refractory B-cell malignancies. Of the 778 patients accrued to this trial, the majority or the largest proportion had CLL SLL, so 317 CLL SLL patients were accrued. Pirtobrutinib is a very unique drug. So in contrast to the covalent inhibitors that we've heard a lot about, pirtobrutinib is a reversible BTK inhibitor. And another very unique property is it has remarkable selectivity for BTK, its target, which you can see based on the kinome selectivity map on the left. So the focus of the Bruin presentations that I'll be going through is on patients who have been treated with at least a prior covalent BTK inhibitor. And so this amounted to 282 patients. And when we take a look at the efficacy data, what this waterfall plot demonstrates is a near universal reduction in lymph node size for patients treated with pirtobrutinib. The color coding depicts whether patients had discontinued their prior BTK inhibitor due to progression, which was about 3/4 of the patients, versus toxicity or other reasons, which was the remaining quarter. The stars indicate whether patients had or hadn't had prior BCL2 inhibitor, and so all the starred patients are those who had prior BCL2 inhibitor. The overall response rate for these groups was right around 80%. And so the response rate was actually pretty similar to the larger group of patients who had had at least a prior covalent BTK inhibitor, but it was similar, 79%, for the patients who had had not only a prior BTK inhibitor, but also a prior BCL2 inhibitor. The pirtobrutinib efficacy is very impressive, and we see efficacy in patients who had a variety of high-risk features, including TP53 mutations, C481 mutations, etc. We've now seen longer follow-up from the Bruin trial, which confirms these PFS benefits in these covalent BTI pretreated relapse refractory CLL SLL patients. So once again, emphasizing the overall response rate of 82%, but we've now also reached the median progression-free survival, which is 19.4 months for this population of patients. The recent ASH presentation by Dr. Woyak demonstrated a slight differential in the progression-free survival rates between patients who were naive to a BCL2 inhibitor versus those who had been previously exposed to a BCL2 inhibitor. So encouragingly, the drug works quite well in both groups with an overall response rate around 80%. However, we are seeing a slightly longer progression-free survival among the BCL2 naive patients of around 23 months compared to patients who had been previously exposed to a BCL2 inhibitor, where the median progression-free survival is 15.9 months. Here is a forest plot demonstrating pirtobrutinib's activity in both those BCL2 naive patients and the BCL2 exposed patients, demonstrating that the response rates are largely similar based on the baseline characteristics of patients being accrued to the trial. I would say the one major outlier is patients with PLC gamma 2 mutations. It mechanistically would make sense that perhaps patients with these downstream mutations may not have as great of responses to pirtobrutinib. And you do see the response rates trending slightly lower, but they're honestly still pretty reasonable, around 50-55%. There are very wide error bars, which is because the number of patients with these mutations is very low, only 18 in total based on this presentation. Nonetheless, I do think it's impressive to see that pirtobrutinib seems to have very similar response rates, even in our highest risk patients, such as those with DEL17P and or TP53 mutation. So pirtobrutinib has also been studied in combination. And so of the Bruin trial, there was actually this phase 1b sub-study where patients could be enrolled and treated with pirtobrutinib with venetoclax or pirtobrutinib with venetoclax and rituximab. The number of patients accrued to these arms was relatively small, so there were 15 patients treated with Perto plus Ven and another 10 treated with Perto plus Ven-R. However, the results that we've seen from either the doublet or triplet regimen are very encouraging, with the progression-free survivals shown with very high response rates around 93 to 100%, whether patients are treated with Perto with Ven or Perto with Ven-R. A significantly higher proportion of patients are achieving a complete remission, which is an expected finding when using venetoclax in combination. And the 24-month progression-free survival was right around 80% for all patients. This trial helps support the ongoing phase 3 trial of Perto with Ven-R versus Ven-R alone. So I'd like to review the current NCCN guidelines for CLL in the relapse setting. And so these, once again, are divided up into patients without del17p TP53 mutation and patients with those mutations. So here I show you the graphic for patients without del17p, where you see pirtobrutinib is now listed in a couple places. And so in the second or third line therapy, you see pirtobrutinib is listed as useful in certain circumstances, specifically in the setting of resistance or intolerance to prior covalent BTKI therapy. One can consider pirtobrutinib. It is also listed in this subset of patients on the bottom, in patients who have relapsed or refractory disease after a prior BTKI and venetoclax-based regimen. And so this is more in line with the current FDA label, where patients need to have 2 prior therapies, including a covalent BTKI and venetoclax, where pirtobrutinib can be considered in addition to a number of other listed agents. In the del17p TP53 guidelines, pirtobrutinib is also recommended in this post-covalent BTKI and double-exposed setting. So there are a lot of ongoing trials to further delineate the role of pirtobrutinib, including in earlier lines of therapy. And so I would like to highlight the 4 phase 3 trials where pirtobrutinib is being examined in CLL and SLL. And so in addition to the trial that I mentioned, where it's being compared as a triplet with Ven-R to Ven-R alone, it's also being compared head-to-head against ibrutinib, head-to-head against BR, and also head-to-head against an investigator choice of Idela with Ritux or Benda Ritux in a pretreated CLL, SLL. So Perto is not the only non-covalent BTK inhibitor. The BTK inhibitor in the non-covalent class that has been studied in a good number of patients is nemtabrutinib. And so this is another potent reversible inhibitor of both wild-type and ibrutinib-resistant C481 mutated BTK. I think it is a bit different than pirtobrutinib as far as its selectivity, which we'll see later in the presentation. But I'd like to highlight the clinical data from the Bellwave study, which enrolled patients with B-cell malignancies, but I'll highlight the CLL, SLL treated patients here. And so they had different cohorts, whether or not patients did have the C481S mutation or did not. And the number of patients accrued is significantly lower, of course, than the Bruin trial, which was 300-some CLL patients. So here we're seeing 57 patients total. And then among cohort A and B, it's 25 and 10 patients respectively. We do see that this drug also has activity, and so the response rate is right around 56% for the entire group. Here are the progression-free survival curves based on the most recent presentation of nemtabrutinib. And so we're seeing something a little different than what we see in pirtobrutinib, which seems to work pretty similar between patients with and without the C481S mutation. In this trial, the patients without the C481S mutation actually seem to have a better progression-free survival. I hesitate to use the word better because the numbers are very small, but nonetheless, the median progression-free survival is not evaluable among this cohort B group of patients. It's only 10 patients, but they seem to be doing quite well. And among the patients who do have the C481S mutation, their median PFS is 15.7 months. So still a very good degree of activity, but I'll be looking for larger numbers of patients to draw firm conclusions on the activity of this drug. So as we continue, I would like you to take a moment to please answer a follow-up poll on the evidence to date with these non-covalent BTKIs in CLL. With that, I would like to hand things back over to Megan.
Thank you, Dr. Coombs, for that section of the presentation. And now we're going to delve a little bit further into non-covalent BTK inhibitors and review some of the data on safety. So here you'll see a slide that looks at selectivity of different BTK inhibitors. And you'll see ibrutinib, again, as a reminder, this is a covalent BTK inhibitor that binds irreversibly. And then you'll see the non-covalent BTK inhibitors, nemtabrutinib and pirtobrutinib. And what we're looking at here are the kinome plots and the selectivity for the BTK target here. You'll see that pirtobrutinib is very selective for BTK, more selective compared to ibrutinib. And then you'll see that nemtabrutinib with the kinome plot is a less selective non-covalent BTK inhibitor when we compare that to pirtobrutinib. And evidence suggests that more selective BTK inhibitors have fewer off-target effects. Again, the clinical data here is all in development, but and we don't have any randomized data right now, but we'll review the safety data we have so far for pirtobrutinib and nemtabrutinib. So this is data from the Bruin study. And overall, pirtobrutinib at this point in time has been very well tolerated. And you'll see here all-cause adverse events, both any grade and then highlighting grade 3 or higher. The most common grade 3 or higher adverse event seen in the Bruin study was neutropenia at 28% of patients. And I think one of the most striking things about pirtobrutinib and the data we have so far is that overall, very few patients have discontinued the drug for toxicity. So just 2.5% of the study population, or 7 patients, had treatment-related adverse events leading to discontinuation of pirtobrutinib. I think it's also important when we think about BTK inhibitors to think about AEs of special interest or toxicities that really were seen to be more common as a class, in fact, with the covalent inhibitors. And what are we seeing with non-covalent inhibitors? So again, staying with the Bruin data here and focusing on pirtobrutinib, you'll see these AEs of interest that are highlighted. So I'm just going to highlight a couple. For example, atrial fibrillation and flutter has been seen with the covalent BTK inhibitors. And so in the Bruin study, there was 4.6% of patients with any grade AFib or flutter, and then 1.8% of patients with grade 3 or higher AFib or flutter. So relatively low with the data we have at this time point with pirtobrutinib. Hypertension is also a common AE seen with covalent inhibitors, and so was explored as an AE of special interest here. 14% with any grade hypertension on the Bruin study and 4.3% with grade 3 or higher. And then you'll see other AEs here. I'll highlight hemorrhage, which grade 3 or higher hemorrhage was 2.1% on the Bruin study. Turning to nemtabrutinib, and this is data from the Bellwave study, now looking at the safety data. So you'll see a data for 112 patients treated here, and you'll see any grade AEs as well as grade 3 or higher on the far column. And when we look here, again, we'll see neutrophil count decreased as the most common grade 3 or higher adverse event. Here are AEs of special interest, again, because of the experience with covalent BTK inhibitors. The clinical trials have focused in on commonly seen AEs. So for hypertension, this lists AEs that are seen in 5 or more patients. That occurred in 30% of the study population here. Other AEs include arthralgia and rash were commonly seen. So now we're going to continue the discussion about the non-covalent BTK inhibitor class and now talk about interdisciplinary care, building the management team, and some additional care tips to be aware of treating patients with non-covalent BTK inhibitors. I'm going to hand things back to Dr. Coombs for this portion of the presentation.
Thank you. So, they say it takes a village to raise a child. I think it also takes a village to effectively treat a CLL patient. And so this graphic demonstrates all of the different healthcare professionals that can go into the optimal management of a CLL management team. And so, of course, I'm a hematologist oncologist, but I don't work in isolation. And so I've been very lucky to build my own team at the institutions that I've worked with. And so to highlight the role of a few other professionals, I can't state enough how important pharmacists are. They constantly are finding med interactions. They help with access to drugs, finding grants when patients have high copays. And so they are just a huge resource. The oncology nurse, also hugely important. They are often the first person to answer patients' questions. They help with education, AE management, and of course, work along with me to provide the best care. Cardio-oncologists have been actually much more important than I would have anticipated, when I first started in CLL, a long time ago now. But with AFib as a significant class effect of the covalent BTKIs, I have ended up having many of my patients go to cardio-oncologists or just regular cardiologists, depending on the patient's preference, if they already know a regular cardiologist, but they can be hugely helpful in coordinating care in the setting of a cardiac AE or even for very high-risk patients as a preventative visit. And then, of course, we also work alongside our pathologists at varying stages in the patient's care. And just to emphasize what Dr. Thompson said, I think it's very important to send our prognostic testing not only prior to the first therapy, but also at subsequent lines of therapy, given that these things can evolve. And so BTKI do have class effect toxicities. And so I'd like to review some of the selected toxicities that we can see with BTKIs. So, with AFib being common, we always have to think about, well, if a patient develops AFib and needs anticoagulation, how can we manage that optimally? It's a recommendation to not give BTK inhibitors along with warfarin. And this is due to a variety of historical reasons, but warfarin was largely excluded with trials, and it is recommended to do non-warfarin anticoagulation. And we have a number of effective agents nowadays that are in this class. Hypertension, of course, it's a no-brainer to manage this with antihypertensives. The thing I'd like to point out is a lot of my patients I found have white coat hypertension, and so I always rely on home monitoring to make sure this is bona fide hypertension as opposed to a white coat event. And, when patients have cardiac arrhythmia or AFib, of course, we have to treat these appropriately. I am out of date on my management of AFib, and so it's always wonderful to have good collaborators and colleagues, cardiologists, cardio-oncologists to help with co-management. I always caution my patients on the signs and symptoms of bleeding, and then I always advise them, of course, to let me know if they need any procedures, given that they should be holding their BTK inhibitors in the setting of such procedures, given the risk of bleeding. And the last point I think is important, but, by the time a patient goes on a BTK inhibitor, I've likely already counseled them multiple times on the risk for infection and secondary malignancies, because I think these, of course, are not just from the drugs. I think they're inherent to the disease. And so this is a conversation I have even with my watchful waiting patients on how to effectively minimize their risk for infection through vaccination and other common sense measures, but also to stay up to date on age-appropriate cancer screening, in addition to at least annual dermatology visits due to the risk for skin cancer. So a few points on unique AEs of some of our current drugs. Acalabrutinib does have a unique side effect, which is it has a higher incidence of headache than ibrutinib, and likely higher than ibrutinib, though those two haven't been compared head-to-head. Fortunately, the headaches are usually not a reason to stop the drug. They're often short-lived, resolve within the first cycle or two. But anecdotally, headaches can be minimized by the use of acetaminophen, and also caffeine can be particularly helpful if patients end up with that AE. Zanubrutinib has been seen to lead to maybe a little bit higher in the way of neutropenia. And so when this occurs, for the first occurrence, they do recommend dose interruption if it's severe, and you can use growth factor support at one's discretion. I typically would consider that if it's a severe neutropenia. Pirtobrutinib can also be associated with neutropenia. And so in the setting of a severe neutropenia, and we'll go through the details on that later, once again, one can interrupt until recovery to grade 1 or baseline. And for the first occurrence, you're able to restart at the full dose of 200 milligrams once daily. I'd also like to mention for some other intolerances that can't be managed with supportive care, sequencing to a second generation BTKI is a useful strategy, especially in the setting of a ibrutinib intolerance. And so this is well supported by phase 2 trials. So acalabrutinib specifically, highly effective in the setting of ibrutinib intolerance, and probably about 3/4 of the time, the patients have improved tolerability when making that switch. Similarly, zanubrutinib has been studied not only in the setting of ibrutinib intolerance, but we've actually also recently seen data using Xanu in the setting of acala intolerance with similar rates of success as far as the measurement of improved tolerability. It's also listed in the NCCN guidelines to sequence to a non-covalent BTKI after covalent BTKI intolerance. And so I think this would depend on, how many covalent BTKIs a patient has gone through. I certainly may consider this in a patient who has had similar side effects from the covalents, which occasionally occurs. So there are a lot of drug interaction considerations. And so this slide depicts the dosing instructions for patients with all of our approved BTK inhibitors, both covalent and then Pirto being the only non-covalent that's FDA approved. And so this once again emphasizes the utility of having a good care team. And I, of course, look through the meds myself, but I am imperfect, and it's wonderful to work with pharmacists who can catch things that I miss. And so there are considerations, of course, with dosing with strong CYP3A4 inhibitors, moderate inhibitors, and of course, inducers. I'd like to mention that this information, which is a lot to digest, is available as a downloadable practice aid, which you can use as a reference after our program. So with that, I would like to segue into our case forum, which will be looking at the sequential treatment planning for the path of least CLL resistance. Megan, I'd like you to go ahead and take our first case.
Thanks so much. So now we're going to delve into some case-based examples. So we're starting here with our first patient. This is a patient progressing on a covalent BTK inhibitor. So Alex is 78. He presented with symptomatic CLL in 2018. At that time, had these symptoms, drenching night sweats. Comorbidities include diabetes as well as COPD and ECOG performance status of 1. We see the white count, 250,000, hemoglobin 9, platelets 70,000. So with cytopenias that were felt to be disease-related after workup in this case. And then looking at his cytogenetic and molecular testing, we see he has an unmutated IGHV status, as well as the presence of both deletion of the p53 gene and a mutation in the p53 gene on next generation sequencing. So for initial treatment, he initiates ibrutinib at standard dosing of 420 milligrams daily. And after 4 years on covalent BTK inhibitor therapy with ibrutinib, has disease progression. So now at age 82, he has a performance status of 2. So we're going to delve into, potential treatment options here. Dr. Coombs, what are some initial thoughts when you see this case on what you're thinking, what factors are going into therapy selection?
So my first thought is, I think ibrutinib was a great first-line therapy for this patient. We have to go back in time 4 years, and I think that was Acala, is available, but maybe not with the CLL label. And so I think he was managed appropriately. I think ibrutinib has a great track record in patients with del17P. He had a kind of early progression. And so I think the median, based on 10-year follow-up data that we saw at this year's ASH, is quite a bit longer than 4 years. So it's a little worrisome for how he's going to do with his future therapies. And now he's older. And so what I would think about as far as his options are, what therapy is going to be the best tolerated for him, but also effective. And so I think the FDA label and our current evidence supports venetoclax-based therapies, but I am thankful that we also have an additional option with pirtobrutinib, which I think, could be in his future as well, if he is a healthy 82-year-old and, may have another, 10 years of life ahead of him.
Absolutely. And just to highlight a few points, I think it's important, and we've talked about this a couple times, but, do we need to repeat the prognostic assessment? Yes. So you can acquire deletion 17p or p53 mutation as well as other cytogenetic abnormalities. I think that, he had these at the time of, initial treatment. And it's common that they would persist, but I would repeat that testing FISH as well as next generation sequencing, as it's helpful to know in a higher risk feature and more common in the relapse setting to have these TP53 aberrancy. I think another point that is helpful for discussion is thinking about resistance mutations and whether resistance testing is standard, should be performed in this setting. And so, we reviewed earlier in the presentation with ibrutinib, the majority of patients do have these BTK cysteine 481 mutations. There are different tests out there. There's next generation sequencing tests, targeted panels that include these mutations. And then there's more sensitive methods available more selectively, things like digital droplet PCR to test for BTK mutations. I would say if it's available, it can be helpful information to have. But two kind of points on that are, one, we don't make the decision to change therapy based on presence or absence of one of these mutations. It's really the clinical picture. Is the patient clinically progressing? Because these mutations can actually occur prior to clinical progression. And so while it is additional information, it doesn't make the decision to change therapy or not. And I would say it's not standard, but if available, can add some additional information. And then I think Dr. Coombs hit really nicely on this. Venetoclax-based therapy there's a lot of data to support its use in this setting. But also now pirtobrutinib can be an option as NCCN listed under certain circumstances, as we saw before, and has data to support its use from the Bruin study here. So I'd say, to summarize this case, prognostic testing should be repeated prior to each line of treatment. The CLL can undergo clonal evolution, and these mutations can be acquired at progression, for example, on covalent BTK inhibitors. The one thing I'll say is IGHV status does not need to be repeated. That is the exception, as that should not change over time. We can do resistance testing, but with the caveat that patients can develop these mutations prior to clinical progression. So the mutations alone are not an indication to make a treatment decision or switch therapy. And we have data now with venetoclax-based therapy or pirtobrutinib for patients progressing on covalent BTK inhibitors. So changing the case up a little bit. So Alex, our same patient with the same baseline characteristics, undergoes treatment with ibrutinib, but then discontinues at the 4-year mark due to persistent arthralgias despite intervention. So this is discontinuation now, not for clinical progression or development of acquired resistance, but actually for toxicity. So as we saw in data presented by Dr. Coombs earlier, the treatment options are a little bit different in this case. And so we do have data to support switch if the discontinuation is for toxicity to another covalent BTK inhibitor, so either acalabrutinib or zanubrutinib, rather than switching classes of therapies altogether. I think, the role of the team is really important here. And in the assessment of whether to switch therapies, it does require some assessment of what that toxicity was. So if it was, for example, major hemorrhage, the other BTK covalent inhibitors do have that risk as well. And so you might want to switch to a venetoclax-based regimen in that case. Same thing with atrial fibrillation. You would want to make sure that the atrial fibrillation was well controlled, that the patient was plugged in with a cardiologist for management and kind of a risk-benefit discussion of trying a covalent inhibitor alternatively as opposed to switching to a venetoclax-based regimen or a non-covalent inhibitor. So really assessing that specific toxicity is really critical in determining a re-challenge with a covalent inhibitor class or switching in that case. So I just want to highlight at this point the CLL Society's Test Before Treat program. So there's really great resources that the CLL Society has put together here that provide some guidance on biomarker testing recommendations. There's a downloadable patient teaching handout, and you can also request hard copies to have on hand in the office. So I'd encourage you to check these out. They're available on the CLL Society website. And there's also the free online patient education toolkit. This has a ton of information on it. You can visit cllsociety.org to learn more. Lot of patient education resources here. And for a disease like CLL, this is incredibly important given the number of options out there and given the number of years patients really live alongside this disease. A great resource to educate patients. So before we move on, I'd like you to take a moment to answer a follow-up polling question on sequential treatment choices in relapse refractory CLL. So I'm going to hand it over to Dr. Coombs as we discuss a different case this time.
Thank you, Dr. Thompson. So this is Christine. She is an 82-year-old woman who was first diagnosed in 2016. She was asymptomatic and so appropriately was on watchful waiting. However, she developed these symptoms in 2019 where treatment, of course, was recommended. Her prognostic testing showed she had unmutated IgHV, no del-17p, and she had hypertension as her only comorbidity, and her performance status was an ECOG 1. Her first-line treatment was with acalabrutinib. However, unfortunately, she also had an early relapse in February 2021. And so her second-line treatment was venetoclax with rituximab, an appropriate choice at this time. Unfortunately, she developed progressive disease in December 2023. And this was 9 months after the end of treatment. Her performance status at this time is now an ECOG of 2. And so just to pause there, Megan, any thoughts on this patient's course?
Yeah, so this is an interesting case. A couple things to highlight here. We have some key baseline information on mutated IgHV, no deletion 17p here. performance status of 1. So acalabrutinib selected as frontline therapy, very appropriate treatment choice, and with data that we've seen to support this use. A very early relapse, though, just 2 years into covalent BTK inhibitor initiation, and then going on to standard of care therapy with the Murano regimen with venetoclax rituximab, and a short relapse after end of treatment. So, relapsing 9 months after end of treatment is on the higher risk side. So now we have this, a patient who's been exposed to a covalent inhibitor, discontinued for progression, and now BCL2 inhibitor, venetoclax-based therapy, and relapse really, really shortly after. Very high risk patient. I would put this into a double refractory category here. Based on what we've seen earlier in the presentation, a couple of things definitely should get repeat prognostic testing. Did this patient acquire a P53 mutation or other high-risk complex karyotype or other high-risk cytogenetic or molecular feature? When I'm thinking about treatment options, I think this is a space where pirtobrutinib really does have data from the Bruin study as the new standard of care in this setting.
Those are all of my thoughts. And so I would agree that this is double refractory, and we'll go through kind of what the difference between double refractory and double exposed is on the next slide. And I think you highlighted all of the points that I already would have highlighted. And so, I would say there's not a total consensus on the difference between double exposed and double refractory. It's been suggested that progression in under 2 years is one cutoff to define someone as refractory to venetoclax. But this is based on expert opinion. Of course, we need more data to better define, what is, the optimal duration of remission to consider venetoclax retreatment. But double exposed is the term we use when patients have relapsed CLL after both at least exposure to a BTKI and a covalent BTKI and ven. And then double refractory is the term we use when they're relapsed after progression on the BTKI and venetoclax. And diving back into our case, let's see what happened. So she relapsed 9 months following the end of treatment. And so I think both Dr. Thompson and I agree this is a very short remission. And so this would be best classified as double refractory. And so as far as our options for our patient, thankfully, pirtobrutinib is now FDA approved and is clearly the best choice for this patient in absence of a clinical trial. So to continue on with her case, she goes on pirtobrutinib 200 milligrams once daily. However, though she responded to therapy, she did experience a grade 3 neutropenia that had an ANC of 0.7, but she also had a fever. And so we do see neutropenia with pirtobrutinib. Fortunately, febrile neutropenia is not as common. However, febrile neutropenia does necessitate holding the drug. And so here I'd just like to highlight some of the safety recommendations based on pirtobrutinib's label. And so pirtobrutinib should be held in the setting of neutrophil count in the grade 3 range, which is under 1, but above 0.5 or 0.5 or greater in the setting of fever. And it should also be held in the setting of grade 4 neutropenia that lasts 7 or more days. And so if this is the first occurrence, the recommendation for the package insert is to interrupt until recovery to grade 1 or baseline, and you can restart at the original dose of 200 milligrams once daily. So next, I'd like to just highlight, once again, another wonderful resource from the CLL Society. This is their medicine cabinet that can help inform patients about dosing and safety considerations for a number of these novel agents. And there, of course, are free hard copies available upon request, and these are non-branded and patient-friendly. And so I think it's a really good resource for patients, especially perhaps those treated in the community where perhaps these drugs aren't used with as great of regularity, or just for patients to educate themselves, which I think can often be very empowering. So I'd like to mention that we have collected these CLL Society resources as a downloadable practice aid, which you can use as a reference after our program. So I'd like to switch up this case a bit. And so let's imagine Christine, our same patient as before, instead of being treated with acalabrutinib in the front line, enrolled on a clinical trial of ibrutinib plus venetoclax. I'll remind you that this has been studied in a number of prospective trials. It's technically not FDA approved in the US, though it is approved in Europe and many other countries. It's a fixed duration of both ibrutinib and venetoclax over the course of a year. And so this is what she received, but unfortunately she relapsed in 2024. And so assuming she started treatment in 2020 and was on the therapy for about a year, 15 months if you include the ibrutinib lead-in, she's had about 3 years in between ending treatment and now progressing. And so how would our treatment options change? And so I think we may see some of these patients in the clinic. A lot of patients have been treated with these combinations. And so Dr. Thompson, would you like to discuss a few of your thoughts on what her options might be?
Yeah, I mean, I think this is a great case to discuss because, as you mentioned, there are patients who have been treated with this regimen as well as other BTK, BCL2 inhibitor combinations, on a clinical trial often. And then we enter really this zone where we have some data, but not a ton. So a lot of data that's being gathered right now. I think it's always important to think about, why the patient discontinued their prior therapy. So in this case, it was because they completed the fixed duration plan therapy. So we don't really have any reason, with that treatment-free remission of about 3 years to think that the patient is resistant to the BTK inhibitor, to venetoclax, or to the combination. And so, outside of a clinical trial, I think, again, acknowledging there's not really a standard in this setting, you could consider retreatment with one or both agents. So really, I think outside of a clinical trial, what I would do, is either covalent BTK inhibitor retreatment or retreatment with a venetoclax-based regimen. In the context of a clinical trial, there are trials that are, looking at retreatment with a BTK inhibitor and venetoclax combination. That is still investigational at that point. And then, the question will come up, should this patient get pirtobrutinib, as a non-covalent BTK inhibitor because technically they've had a covalent inhibitor and BCL2 inhibitor. I don't think we have, such great data on that class of agents. And I would be tempted to stay, with a covalent inhibitor or venetoclax-based retreatment strategy. But I acknowledge there's a lot of data that needs to be gathered in this space and a lot of different directions potentially to go here.
Totally agree. And so I think that's a good segue into thinking about how we sequence our therapies. And so, of course, it depends on, well, what did a patient get in the first line? And then what are our next best steps? And so for patients who start with a covalent BTK inhibitor, I'd say the current standard of care is venetoclax, typically with rituximab, which is well studied. Of course, we've already alluded to the fact that the Murano trial that led to approval didn't have a lot of post-covalent BTKI patients, but nonetheless, this is a well-vetted regimen that I've been using for the past many years. However, non-covalent BTKIs can be considered in certain circumstances, and that is listed in the NCCN guidelines, though is not technically the current FDA label. Single-agent venetoclax is also another great option. It's in this third line setting that I think the use of pirtobrutinib is much more clear. And so if a patient falls into this double refractory range, which, a lot of people say 2 years, I might think of retreatment ven if it's a little less, depending on how well they tolerated the ven. And so, acknowledging that timeline isn't set in stone. But if it's clear double refractory, like our patient case where she progressed 9 months after end of therapy, I think non-covalent BTKI is the way to go. However, if they had a longer remission and they did, really well with the venetoclax, I think you could have a little bit more leeway between your choices where non-covalent BTKI is certainly appropriate, but, maybe ven retreatment is also a good option. And so moving into another commonly used standard of care in the front line is Ven-G. I use a lot of it in my own practice. In the second line, I think we have options. And I think my enthusiasm for retreatment with Ven goes up the longer that the patient is in remission. And so if a patient had a really long remission and did quite well with the Ven in the front line, I would be very enthusiastic about retreating this patient with Ven plus minus a CD20. However, if it's a shorter remission or if there were significant tolerability issues with the venetoclax, it's also very appropriate to use a covalent BTKI in the second line setting. And then once again, when we get into the third line, we're thinking about non-covalent BTKI, especially if there's not a long duration of remission, if you did Ven retreatment as the second line. And just as Dr. Thompson alluded to, if there are patients who are getting fixed duration covalent BTKI and venetoclax in the front line, we really have very little data on what to do in the second line. There was a really nice presentation at ASH looking at the patients treated on the Captivate trial who relapsed and got retreated either with single agent ibrutinib or the combo of ibrutinib plus venetoclax. Unfortunately, it doesn't look like resistance mutations are seen with any frequency. There were no BTK or PLC gamma 2 mutations. And so I think retreatment with either of these agents is appropriate based on everything Dr. Thompson discussed in the prior slide. And so I would like to lump in a different category here, which is intolerance of a BTKI. So I've primarily been focused on patients who progress on these agents during my discussion on this sequencing landscape. However, in a patient with intolerance, I always would encourage the consideration of sequencing to a more selective covalent BTKI, such as Acala or Xanu. I'd also like to point out that, if a patient's in a good clinical remission, you don't have to start another agent right away. I am always a fan of a treatment holiday and waiting for a patient then to progress after a period of watchful waiting and then applying one of these agents. However, additional options are sequencing to pirtobrutinib, and you can also sequence to venetoclax. And so I've done that frequently for patients who I just thought it was a little too risky to go back to a covalent BTKI. And I think the perfect example is a patient with a severe bleeding event, given that that's something that is relatively common between all of our covalent BTK classes. So some final take-home points on our modern BTKI sequencing in relapse refractory CLL. I do think that pirtobrutinib is very clearly the new standard of care in double refractory CLL. Of course, we need to continue to do more work to understand what double refractory really is. What is that optimal time period where you can reconsider Ven retreatment? There are, of course, these additional settings where pirtobrutinib, as our only approved non-covalent BTKI, may be useful. And so I certainly would also consider its use in double exposed CLL. But in this situation, I would just weigh the pros and cons of Ven retreatment with the patient, which would be influenced by their prior length of remission. And then, of course, how well did they tolerate the Ven? Next, another setting to think about pirtobrutinib is in the setting of covalent BTKI intolerance. And so in this setting, switching to an alternative covalent or venetoclax is in fact supported by current evidence and guidelines. But the Bruin trial, in addition to the NCCN, also support the switch to a non-covalent BTKI, pirtobrutinib specifically in this setting. So with that, we have already received a few questions from the audience, and we welcome additional questions that we'd love to handle during this time period. So, Dr. Thompson, I think one of these questions is important, and so I'm really curious on what you do here. Are you, in fact, testing all patients for BTKI resistance mutations at relapse? And what's your rationale for testing prior to starting a BTKI even?
Yeah, I think this is a great question. I mean, as we talked about during the presentation, these BTK mutations we do know occur in many patients at the time of relapse on a covalent BTK inhibitor. And, we've even seen data on reports of additional mutations with non-covalent BTK inhibitors. I would say I do test patients, at the time of progression on a covalent BTK inhibitor for these resistant mutations. But part of that is due to I do have access to that testing. And like I mentioned, I don't think it should determine, switching therapies. I think the big take home is that, it's additional information to have about the CLL biology, but at this time, the presence or absence of a mutation doesn't determine that the patient is progressing on that treatment. That is really, really the clinical significance. So I think a lot of this will be on the availability of the testing, and I do baseline genetic sequencing prior to each line of therapy. That does include the BTK, testing. But I think the take homes are that this is additional information, but the clinical assessment of progression really, really is key and should be determining treatment. The other question that jumps out to me on here, Dr. Coombs, is I think you highlighted this well in the Bruin data, but kind of the experience of non-covalent BTK inhibitors in DEL17 CLL, or even we can think about this more broadly, high-risk CLL, either from your experience or the Bruin study experience.
Yeah, so I think that was one of the most impressive things as far as being an investigator on Bruin. I put some very high-risk patients on the trial, and I think it also agrees with the clinical trial data. The drug works in everybody. I mean, well, not everybody. It's an 80% overall response rate. But, of the patients I treated, I had a very significant proportion of patients with very high risk features, very heavily pretreated. And I have been profoundly impressed with the efficacy of the drug. And I think when we look at the larger population of patients from the Bruin trial, the response rates are very similar based on all of these high risk features. And so the question specifically alludes to DEL17P, but the response rates are very similar, and the progression free survival very similar. And so the drug just performs, phenomenally well, even in the highest risk patients. And so my experience has been very favorable, and it would definitely be my go-to in patients who had been, failed by their other standards of therapy, as we've discussed.
Thanks. Yeah, I agree. It appears to have great pirtobrutinib, great activity in high risk subgroups. So just to close things out here, you can visit us peerview.com/RRCLL24. I'm going to encourage you to complete and submit your post-test and evaluation for credit. As highlighted throughout the presentation, you can download the practice aids, and you can also download the slides from today's presentation. You can watch the replay of this event in the next 24 hours, and the online activity will be available in the coming weeks. And you can request a live meeting at your institution as well. So thank you so much for your attention today and for joining us. A really informative presentation. I want to thank Dr. Coombs for her collaboration in this program, and also can join us the conversation on X at PeerView. So thank you for your attention today. I really enjoyed interacting with you in this event.
And thank you.